Thank you very much for the organizers for such a great honor to be here today to talk to you about my work. My friends and colleagues asked me to talk about next generation treatment. And I'm going to be talking to you about what I feel is going to be the next generation therapies in cancer in general. I'm a gynecologist by background, so I'm going to be focusing on ovarian cancer. And what I feel is going to be key in the future is essentially targeting the invisible. So I understand that there is a clear focus from RDIA on prevention of non-communicable diseases, including cancer. Prevention, what I'm trying to persuade you today and convince you is that next generation therapies are about targeting the invisible. And by that I mean preventing pre-cancer initiation and progression, but also eliminating minimal residual disease at the end of treatment. And I'm going to be focusing on ovarian cancer. These are just my disclosures. So in the case of ovarian cancer, we know that, the vast majority of the most common type of ovarian cancer, which is high-grade serous ovarian cancer, originates from the fallopian tube. There's about a 20-year gap from the very first transformation insult to actually clinical presentation. So there's a lot of opportunity for us to intervene for prevention. A few years back, now we published this work where we did single-cell RNA sequencing of the fallopian tube epithelial cells and identified the two known fallopian tube cells. There's nothing new about knowing that in the fallopian tube cells there are secretory cells and ciliated cells. But what we found with single-cell sequencing is that there are 4 additional subtypes of secretory cells that we didn't know about, and we named them differentiated keratin 17, EMT cluster, and cell cycle cluster. What I'm going to present to you in the coming few slides is the evidence that we produced from our lab in Oxford to support the idea that ovarian cancer actually originates from the fallopian tube. And then after that, I'm going to transition to another topic, which is how do we harvest the power of resident immune cells in the fallopian tube to stop ovarian cancer from starting altogether. So this is some work that we have produced in the lab showing that the key stem cell of the fallopian tube epithelial cells are driven by the Wnt7 Frizzl5 pathway. And based on this, we were able to make organoid models in the lab that closely mimic the complexity of fallopian tube epithelial cells. We then started to separate these 5 different subgroups based on their molecular characteristics. So this is working entirely on normal fallopian tube epithelial cells, and identified a 52 gene marker panel that very nicely separate between these 5 subtypes. And then ask the question whether these 52 marker gene panel could be used to classify established ovarian tumors. So we started by mining data sets that were already present, already published in the literature. And this is one example. Hello? Can you hear me? Huh? Is this working? Now it's working. Now it's working. Now actually both are working. So. Okay, so we then asked the question about whether these 52 gene marker panels, which we named the Oxford Classic Marker Panel, can separate the different subtypes of established ovarian tumors. And indeed, using these 52 gene marker panels, we were able to accurately separate 5 different subtypes of established ovarian cancers. But the most important thing here is that we found that one particular subtype, which is the EMT subtype, was closely associated with poor prognosis. So this is the result from 9 different data sets that we mined and found that every time we checked the correlation between EMT and poor prognosis, we found it. We then went on to validate this in collaboration with 2 other groups, one in Hammersmith and one in Italy, and again found this amazing reproducibility that the EMT subtype or the EMT scores that are derived from the Oxford Classic associate closely with poor survival in patients with ovarian cancer. So this, I'm going to pause here and just tell you what I have explained to you over the last few minutes. What I've explained to you is that the fallopian tube seemed to be a credible source of ovarian cancer origination. And I have shown you that when using the molecular markers of the different subtypes of the normal fallopian tube, we are able to classify tumors and we are able to predict prognosis in an unprecedented accuracy and reproducibility. So that really established for us as a group that the fallopian tube is the origin. But I want you to look at this. So if you look at this, at these photo, the origin of the tumor on the left side is microscopic. It doesn't invade the fallopian tube, it doesn't do anything. While in the same patient, the tumor itself is metastatic, invasive, horrible. And why is that? So we asked the question whether the tissue-resident memory cells in the fallopian tube are actually doing a great job in constraining the precancerous lesion of the fallopian tube. So to address this question, we asked, if that was the case, if we took the normal fallopian tube of a patient with ovarian cancer and extracted the memory cells, the T cells in this fallopian tube, and compared it to the tumor that exists in the same patient, we would see a high degree of overlap of the individual clonotypes of T cells. So to do this, we essentially extracted immune cells, thousands of immune cells, from the fallopian tube and the tumor, from the same patient. And then we started looking at this by single-cell T-cell receptor sequencing combined with RNA-seq using the 10x technology, and identified different subgroups, but I want you to focus your attention on this exhausted memory cells, because these exhausted cells are essentially cells that react to neoantigens specific in the tumor. And these are the neoantigen specific T cells. They are exhausted because of repeated, persistent stimulation by the tumor microenvironment. And what we found was something that I really did not expect at all, which is this tremendous overlap of the individual TCR clonotypes between the normal fallopian tube and the tumor of the same patient. So what we are finding is up to 25% overlap. So this is if you pick up cell by cell, look at the T-cell receptor in the tumor, and go and look at the T-cell receptors in the normal fallopian tube, you find about a quarter of the ones that you find in the tumor are represented in the normal fallopian tube. And this is really tremendously amazing because if you compare this to the blood, overlap with blood TCRs, you see less than 1% at the most. Not only that, but if you look at the most expanded clones in the tumor, you see that 80% of the top 10 to 20 expanded clones, so these are clones of T cells that are expanded because they are exposed to the neoantigens of the tumor. And if you look at those, you see that 80% of those are represented in the normal fallopian tube. So this started to indicate that actually the more the T cells are expanded on the left-hand side, the more there is a degree of overlap and the more convincing it is that these T cells are actually tumor-specific. And if you looked at the characteristics of these T cells in the fallopian tube that have shared T cell receptors, you will find that they are exhausted memory cells, so indicating that, again, giving more evidence that they are neoantigen specific, that they are tumor specific. So what am I trying to say to you? I'm trying to direct your attention to this very interesting phenomena. How can you have an entirely normal fallopian tube, yet you see the T cells and their TCRs are essentially recognize the tumor, which is anatomically in an anatomically distinct, far away location. And this to us indicated that these T cells were exposed to the tumor at its very origin, at initiation. But this is still just some evidence, and I'm going to show you the rest of the evidence that firm up the hypothesis and the conclusion that we are sort of heading towards, that these T cells have actually been exposed to the tumor at its very origin. So this is, again, further confirmation. If you look at the classical exhaustion markers, PD1, LAG3, CTLA4, they are all significantly overexpressed in the cells in the T cells with shared TCRs compared to the C cells with no shared TCRs. And it's the same in CD8 and in CD4 cells. But if you then take the gene expression, look at the gene expression pattern of these cells with shared TCRs and compare them to the gene expression pattern of cells, of published data sets of cells that are known to be neoantigen specific. And here we chose the data set from Dr. Rosenberg's paper where he identified the gene expression signature of T cells that are specific to cancer antigens. And you look at the correlation, it's 0.86, really indicating that these cells with shared TCRs appear to be neoantigen specific. But the very powerful thing that we also found was that these TCR cells with shared TCRs in the fallopian tube appear to be less exhausted than the tumor. That indicates that these neoantigen-specific T cells could be utilized for cell therapy. Okay, so what am I trying to propose to you? What I'm proposing to you is to sort of look back, as if we have like crystal ball, look back in history of the tumor development and think and imagine what is the working hypothesis that we have. And the working hypothesis is simply that at the beginning of tumor initiation, the T cells in the fallopian tube recognized these cells. Antigens were presented by antigen-presenting cells to the lymph node in the pelvis and the abdomen. And these pelvic and para-aortic lymph nodes became educated to the presence of these antigens. When the tumor then metastasized to the abdomen, these lymph nodes sent their T cells, troops, to they were already primed and sent their T cells to the tumor. But to be able to really put that conclusion, make that powerful conclusion, we needed to do provide direct experimental evidence for that. So what we did here was we took the T cells of the fallopian tube and co-cultured those with organoids of the tumor, anatomically distant tumor. And what we found was that these T cells starting to recognize and the antigens that are presented in the tumor. As seen here by this L spot, you see the dots. The dots that are present indicate that these are T cells that have memory to the tumor. Not only so, we then did deep sequencing of the tumor, identified the antigens that are present in the tumor, made those antigens using peptides, mutated peptides, to mimic the mutations in the tumor, and then confirmed that the tumor that we are dealing with has all the characteristics of high-grade serous ovarian cancer, as seen here by genomic instability and driver mutations that are known to be present in ovarian cancer, such as P53 and BRCA, and so on. But then what we were trying to say is that if you now take those mutations, make peptides that mimic those mutations, and then culture those with T cells that we obtained from the fallopian tube, can we provide direct evidence that the fallopian tube cells, immune cells, have seen these antigens? That's the experiment. That would provide you direct evidence of memory. So what we did, as I mentioned, we sequenced the tumor, identified the mutations, interestingly found that the tumor has most probably arisen from a clone in the fallopian tube cells that had shared mutations between the fallopian tube and the tumor, originally at very low allele frequency in the fallopian tube, but then these mutations expanded in the tumor. But this is the key experiment that I want to show you. If you see, what we have found was that 2 mutations that were present in the tumor, if you make the mutant peptide of those, expose the T cells to the mutations, you see a significantly higher reactivity compared to if you expose the T cells to the wild type. And this provides direct evidence that these T cells have been exposed to antigens in the tumor. So this is no longer a working hypothesis. I am biased, but I think that this evidence indicates that these T cells have, in fact, been exposed to the tumor, even though that the fallopian tube looks completely normal. So the work provides further strong evidence that the fallopian tube gives origin to ovarian cancer. And to our knowledge, this is the first demonstration of tumor reactivity of fallopian tube TRMs in ovarian cancer. And the question now is, can we now exploit this finding to train those TRMs, train those tissue-resident memory cells, T cells, so that they can fight early transformation at the beginning in the form of a vaccine? Can we stop ovarian cancer from developing by educating these tissue-resident memory cells? That's really the indication from what we have found. So we proposed a vaccine design to Cancer Research UK, and we were very grateful to them for funding this project. And this is now something that will be starting in the next month or two, where we will expose T cells from healthy volunteers and from naive T cells from patients with ovarian cancer to a number of mutations and tumor-associated antigens that we believe can form a strong vaccine to educate the immune system to prevent ovarian cancer. To my surprise, last week this gained tremendous publicity. I was on for the very first time. I had my one day of fame in the BBC, and you name it. I was interviewed by people excited about the possibility of developing the next ovarian cancer vaccine. So I strongly believe that the next generation therapeutic is not actually in the form of a traditional therapeutic, but in the form of prevention to intercept the process of transformation when the tumor is at the very, very early stages. And we have already seen successes of this strategy in HPV vaccination, for example, against cervix or hepatitis B vaccination against liver cancer. In the last 5 minutes or so, I'm going to tell you about the other area that we are very interested in, which is, again, targeting the invisible, which is minimal residual disease. So let me explain to you what I mean by that. The idea is that when you treat patients with solid tumors, and in this case, ovarian cancer, you often reach a stage where you can no longer see a tumor in the abdominal cavity. It's all gone, or we think it's gone. But then what happens is that without about a year of stopping treatment, in ovarian cancer, 70 to 80% of our patients would come back with recurrence. And the reason for that is the presence of cells, cancer cell collections, in the abdominal cavity that we can't see, that we call minimal residual disease. And at the moment, after completion of traditional treatment, we do nothing. We just have a period of observation. In my opinion, that doesn't work, and we shouldn't be the case. We know that these cancer cells are there, we just can't see them. We need to start thinking about how do we intercept those cells, how do we stop them from regrowing, and how do we change clinical trial design in the next generation of clinical trials to have a readout, a recurrence, not reduction of tumor size. And that's the kind of ethos of what I'm trying to propose to you, which is intervening with minimal residual disease at the stage of it when it's still invisible. So what we have been doing in the lab is nothing new. This is adoptive T-cell therapy, where essentially in any tumor, you have T-cells that are reactive to the tumor and a collection of T-cells that are not reactive, that are bystanders. And what your aim with adoptive T-cell therapy is to identify the ones that react to the tumor, take them out, rejuvenate them, expand them, and give them back to the patient. And that's fine to do in the context of bulk disease. But the difficulty is when you try to do that for minimal residual disease. Because trying to identify mutations in minimal residual disease is really, really difficult. Because sequencing of very tiny amount of DNA on a whole genome scale can result in a preponderance of false positive that will make subsequent analysis very, very difficult. What we have done in the lab, we've been very fortunate to invent a method that we call DigiPico, for digital analysis of picogram quantities of DNA, to identify accurately mutations present in minimal residual disease. This then enables us to use those mutations or mimics of them in the form of mutated peptides, essentially as baits to fish out the T cells that are specific to the tumor. In order for this to work, we have also advanced an AI algorithm that we called MutaLex. We've now developed MutaLex 2 that has incredibly high sensitivity of more than 70% for this picogram quantities of DNA and a very high unprecedented specificity of more than 98%. I'm sorry this is upside down. I don't know why this happened. But what I want to show you with this slide, if you can bear with me, is that actually if you use the T cells from the algorithm that we proposed on the right-hand side and compare it to just if you took any T cells from the tumor on the left-hand side. In orange is the cancer cells. You see on the left side, if you go from down up, you see that the cancer cells actually increase, even though they have T cells around them. On the right-hand side, if you select the neoantigen-specific T cells using our technologies targeting minimal residual disease and incubate these T cells with the tumor, you see right at the top, there is hardly any cancer cell remaining. So in conclusion, what I want to say is that my vision for the future is for next generation opportunities is targeting the invisible. And that is either in the context of targeting the precancer cells to stop them from growing and becoming bulk tumors, and or targeting the cells at the minimal residual stage disease to stop it from progressing and becoming a full-blown recurrence. And I end my talk by thanking our funders, Ovarian Cancer Action, Medical Research Council, University of Oxford, but at my very heart, my colleague, Professor Enzo Cirondolo, who is a great immunologist who actually discovered the way antigens are presented to HLA system through the TAP proteins. Professor Cirondolo unfortunately died about 3 years ago of lung cancer. And this is a photo of us both just about to run for 10K run. I really owe a lot of what we are doing in the lab to his thoughts and expertise. God bless his soul. Thank you very much for listening. And I'm happy if the organizers allow me to ask questions. Thank you.
Have such a wonderful speaker amongst us. I would really encourage our audience to please ask questions. Feel free to raise your hands. He's traveled all the way. Let's have this platform as a knowledge-sharing platform. I'd like to encourage you to please ask. Introduce yourself briefly and please ask your question. Please raise your hand and we'll pass on a microphone to you. Special prizes for the first question.
Kevin, I see you, Kevin.
Check, check. Dr. Ahmed, nice to see you, and congratulations on your fame, recent fame. In your opinion, or based on what you know now, how far away do you think we could be from this vaccine?
Thank you. I think what we are aiming for is to test the components of the vaccine in the coming 2 to 3 years using this new funding that we obtained from Cancer Research UK. I am really hoping that in 2 to 3 years' time we will be starting a clinical trial. And I am an optimist in that I strongly believe that if something is working and you start a clinical trial, you will start seeing benefit from that and you'll start having impact on women and patients while it's in development in clinical trial. I don't want to think about how many years clinical trials will take to finally get it available through healthcare systems, but my ambition is that the clinical trials will start revealing earlier on that this vaccine is working. So I would hope that we will start a trial in about 3 years' time. Thank you. I see a question here. Yeah.
Thank you so much, Doctor. Very informative talk. Everyone who is working on this research are amazing people who are going to benefit us tremendously. Now, my question is, when the vaccine is done, because I am also an optimist, will it be directed towards a specific, a certain demographic, the ones with the certain gene that you mentioned, or will it be available to all women who could, just young women, just like the HPV vaccine?
So the components that we are proposing for the vaccine would work on to prevent all types of high-grade serous ovarian cancer. And that is people with genetic predisposition and people with not. But I think that to be able to check quickly if the vaccine is working, we would first most probably start a clinical trial on women with a genetic predisposition to getting ovarian cancer, such as carriers of BRCA1 and BRCA2 mutations, because those have a risk or lifelong risk of 40%. In some cases, we think 80%. But hopefully, once that success has been demonstrated in these patients, we could then generalize it to other populations. I see a lady here with a raised hand.
First, I'm just saying thank you, doctor. Then my question is, when it will be the last stage to give the vaccine? When should we say there is no future in the vaccine?
Sorry,
The last stage to take the vaccine.
is
So
this-
after that, there is no any benefit of taking it.
I'm not sure I got your question completely.
The question is, in what stage can or could be the last chance to have the vaccine?
Oh, I see. I mean, at the moment, for women with BRCA1, BRCA2 mutation carriers, the current recommendation is for them to have tubes and ovaries removed around the age of 35. So my thinking is that, and this is really looking at in the future, is that what we are trying to develop is something that women will start getting way before that age of 35. So, you know, from 20 onwards, perhaps. But I would think that perhaps around the age of 34, 33, just before that recommended age, because that's where we start seeing the increase of ovarian cancer incidence, even in women with genetic predisposition. So I think, you know, before the age of 35 is probably fine. Ashwa. Ashwa.
Hi, Ahmed. Thank you for the outstanding talk. I have two questions for you. First of all, I would like to say congratulations on the receiving of the award and good luck. My question regarding the vaccine, do you think the same approach can be applied on other cancers? And are you thinking of that? And the second question regarding the Singular Bio, when do you think would be a clinical practice and can be used in the clinics to treat ovarian cancer patients? Thank you.
Really great questions. So the first question, yes, I think that this is the same principles apply for other cancers. In fact, in Oxford, my colleagues are preparing also a vaccine against colorectal cancer, particularly in patients with Lynch syndrome, and also one against lung cancer. And I think the clinical trials for the ones targeting lung cancer will be starting soonish. So yes, it's a very similar concept. I know that similarly in breast cancer, they are also developing something, but for treatment. But also people are thinking of starting it for prevention. Regarding Singular Bios or the approach for targeting minimal residual disease, we have to go for point-of-care manufacturing. And my friend and colleague Kevin is sitting there.
It's fine. I don't.
So we need lots of these mobile rooms in hospitals and healthcare delivery systems to be able to actually get to the point of care manufacturing. In the same way as bone marrow transplantation. When you're doing bone marrow transplantation, you don't send your bone marrow cells to a central factory that would condition it in any particular way and then bring it back to the patient. It all happens in the hospital. I strongly believe that this is very similar to autologous T-cell therapy and other forms of therapy. It's that point of care. That's, I think, that technology of developing clean room, making it easier to use, would enable advances in this sort of these sort of therapeutics. Thank you.
Hi, so I'm a research student actually based in London in UCL. I've been working in nanomedicine and targeted therapy. So I understand that the delivery is going to be intravenously through a vaccine. So is it through nanoparticles or a liposome system? I was just wondering what system are you going to be using? And if you were to go in that trajectory, essentially in the field of nanomedicine, we are facing lack of translation due to our minimal understanding of the behaviors of our delivering agents intravenously, due to the effect of our serum proteins and the formation of the protein corona. So you said in your presentation that this is going to be targeted with a large demographic, but our serum proteins differ due to multiple factors, starting with our genetic variations. So how do you think your approach is going to be targeting those limitations or evading the lack of translation as so?
Sure. So at the moment, this research is going to be going hand in hand with testing the constituents of the vaccine. So we will also be testing the possible carriers. And we would probably go for carriers that have been tested widely in COVID, for example. So we are very lucky in Oxford to have the Chadox vaccine carrier, for example. For colleagues have developed the Chadox, which is the basis of the so-called Oxford COVID vaccine. We will test that. But also mRNA vaccines that are delivered in lipid nanoparticles are also very powerful, have proven to be very powerful. They're not without side effects, as we all know, but I think that they have been tested widely globally, and this is why this excitement, there is this sort of renewed excitement in vaccines, because if you think about it, 6 years ago, people were still reluctant conceptually to think about vaccines for cancer, but because now there are so many new technologies that have proven safety and efficacy for delivery of vaccines, that there is this increased renewed interest. So, yeah.
Sounds great.
Thank
you.
Right. Fine.
Thank you very much. I would like to welcome you in Saudi Arabia.
Thank you.
My question actually, is there any evidence which has been testing the correlation between different types of cancers in general and correlation between cancer of ovarian cancer with oral cancers?
The question is there any correlation between ovarian cancer
and
other
oral cancer?
Oral cancer. Oral. Yeah, I don't think that there is any epidemiological correlation between the two. I'm not aware of any epidemiological correlation. But it's an intriguing question. I would like to ask you, what is the basis of that? Why do you think that there might be a correlation?
I'm consultant orthodontist, but in principle I am dental surgeon anyway. We know that oral cancer is very common.
Yes.
The commonest type of cancer is the head and neck cancer. From that point, my interest to know, is there a really correlation between oral cancer and ovarian cancer?
I see.
Thank you very much.
Thank you. Thank you very much for your attention.